we record this, Shri Prakash, so that we create
Yeah.
a kind of a library of resources for people to learn as we go forward. Do you want to say anything about yourself, Shri Prakash? And anything that I
I
might
mean,
have?
I'm an endocrinologist. My special interest is in diabetes and obesity, and I had a long association with psychologists, mainly working in the field of depression and diabetes, and the role of depression in worsening diabetes and the role of diabetes in worsening depression. And also in health behavior change, trying to see the adherence to medication use, diet, exercise. So I've been working with one of the psychologists at the University of Louisville, so to, to do some work in this area. Mhm.
That could also kind of generate some questions in that area because
Mhm.
the patients have a variety of different problems, including depression, even though what brings us together is psychosis. Uh,
Mhm.
but in psychiatry, all these are disorders of a kind of a spectrum. We see a little bit of everything in everybody. So, so let me share my slide, which will be of interest. So, can people see my slides?
Yeah.
I'll put it on slideshow mode. Let's see here. Okay. Yeah, so this is someone I have been taking care of. And so this is a 32-year-old married Indian woman. She has been diagnosed with schizophrenia about 4 years ago. Um, she was briefly treated with risperidone in India for a first psychotic episode about 4 years ago. She responded well for a brief treatment, but then she stopped taking medications because she got married, and after coming to the US, she did not think, she did not want to have any kind of an illness, um, and so she just stopped taking her meds. But of course, her delusions surfaced, and she had very little insight. She refused mental health treatment, and the husband, who was kind of at a loss to what to do, um, and her delusions were quite prominent in the area of suspecting him of unfaithfulness and constantly monitoring his whereabouts and so forth. So he came to know that there was a psychotic episode previously, and she had responded to risperidone. So he managed to get some pills, risperidone, from India, and gave it to her because she would not want to see a psychiatrist or any mental health professional. So he started treating her by giving it in orange juice, unknown to the patient. So she started improving, um, but she put on over a period of almost a year, put on about 40 pounds. She has a family history of diabetes in both parents. So, because of the weight gain, she agreed for a medical workup, and she showed that she had a significant um, diabetes type 2 with a HbA1c of 9.2. She continued to have delusions. She continued to refuse psychiatric treatment, but she agreed for treatment for of her diabetes because she knew diabetes runs in her family and she had put on weight. So she was put on by her PCP on metformin, and her HbA1c came down to around 8, partially getting better, but she didn't lose much weight. She only lost about 5 pounds. So this is the situation. So from a medical and psychiatric point of view, how would people approach this? Now, I was at this point still seeing her kind of more as a curbside consult by the husband. I had not seen her. She lives in another state, and I have been treating her through a former colleague of mine in another state. This is the situation.
So from the medical point of view, from the point of view for diabetes, the approach that we take has certainly in the last 10 years changed quite a bit. In the past, we went through a different algorithm trying to get the glycemic control. But now we are looking at it from the perspective of not only just the blood sugars, but we pay a lot more attention to what we would refer to as cardiometabolic risk, which includes the, in addition to the blood sugars, about their weight, their um, vascular risk factors like lipids and blood pressure, and microalbuminuria and liver enzymes. So from that point of view, we try to use drugs that are beneficial for all of these with kind of, I think currently there is enough data to support the use of the two new classes in the 10 years, which is the SGLT2 inhibitors and the GLP1 uh, analogs, or GLP GIP dual agonists. So that would be our approach to try to address this particular problem with the A1C being high. And in a young person, we certainly would like to get the A1C much lower.
Yeah, so let me give you a little bit of additional information that is relevant here.
Mhm.
Blood pressure is fine. Lipids are fine. Fine in the sense a little bit of the upper end of the triglyceride levels, but otherwise, her profile is fine. Liver enzymes are fine, and so that's the situation. So it's just the weight gain
Mhm.
and hyperglycemia. So the question that brings up is you mentioned about treating the the blood pressure and the lipid profile, and looking at the liver, if there is any fatty liver and so forth. So, but with this clinical picture, with uh, a diabetes in the absence of any hypertension or hyperlipidemia, would you prophylactically start her on something like a statin? Would you start better put her on an antihypertensive to protect her kidneys, things like that?
So, in this particular situation, using a statin, she's only 32. So I would be a bit more cautious about it. For a 32-year-old female of a reproductive age group, you have to be a bit careful because statins are contraindicated during pregnancy. So we have to be careful about that. And if you look at her risk itself, we would not automatically put her on a statin, unless I have some other high risk indicator like a very strong family history or something like that. Otherwise, I would not straight away go and add a statin to her regimen. you know.
What about an antihypertensive?
Again, if her blood pressure is under control, if she's not hypertensive, we don't use. At one point, we automatically used an ACE inhibitor on all patients with diabetes. Currently, we don't automatically put them on an ACE inhibitor. If her glycemic control is not good, we have two choices there, of using an SGLT2 inhibitor, which would also help with her blood pressure and also be renal protective. And of course, managing her weight with lifestyle intervention plus GLP1 GIP analogs would be probably the best way to deal with it. Uh, in fact, the biggest barrier in that whole situation will probably be her insurance coverage for the cost of these medicines.
Yeah, right.
Mhm.
That's important to consider. Dr. Mayer, you had a question.
Yeah. So I think one of the things I was wondering was, I mean, the medication itself that you're using to treat her illness might not be the best one for, like, why not just switch her to something that's not going to cause so much metabolic disruption? And if is there anything else we could check, like a prolactin, to see if there's any other like metabolic stuff going on there, because of the risperidone? Like if you put her to Abilify, wouldn't that just kind of knock out a bunch of these issues?
So I think in the risk profile for weight gain and diabetes, risperidone is kind of moderate. Abilify certainly would be a low risk, for this kind of a problem. Usually, as I don't deal with that particular medicine, I make a recommendation to the treating psychiatrist to see if they can change the medication. That is a judgment that the psychiatrist can make, and that is something that we would welcome to see if we can change those medicines
Yeah.
to see
So,
if they can use a better
yeah,
profile.
I think this is an important question. As you very rightly pointed out, Shri Prakash, there is the distinction between some antipsychotics that are more likely to cause weight gain and metabolic syndrome and glucose dysregulation compared to the others. The worst culprits are olanzapine and clozapine,
Hmm.
Seroquel, that is quetiapine, and somewhere in the intermediate range are like risperidone and paliperidone. And those that are, allegedly less likely, even though we do see a lot of problems even with others like aripiprazole and some of the more recent ones like lurasidone and so forth. We do see weight gain with the more so-called
Hmm.
neutral, metabolically neutral antipsychotics as well. In this case, this is a psychiatric problem, Max. So here, she doesn't even believe that she's getting any treatment, psychiatric treatment. So the husband is smuggling some risperidone from India and putting it in orange juice and giving it to her. We're kind of stuck here.
This is not good. That's not a good
We're
situation.
not a good situation. So I did not know what to do myself. So all the best we can do is to kind of turn our eyes to the other side and let the husband manage the psychosis and so on. But there is more to this story, which we'll come to. Any other questions?
I wanted to ask, you mentioned, probably the biggest barrier would be cost and actual access. Is that so? I had heard about the, shortage of Ozempic. Is that still a thing that's affecting folks? And how does access kind of play into all of that?
Yeah, it is still affecting individuals in terms of access to both Ozempic and Mounjaro, so there is a limited amount. For example, right now I'm at the VA. We have no new starts. For this month. I think we will be okay by the 15th or something. But we do have a shortage, so we're not starting anybody new so that we can continue to give those who are already on it. And I think they're becoming a bit more stringent on many of the insurance companies in terms of prioritizing diabetes versus weight. So people, when I write it for diabetes, they're more likely to approve it than if I write it for weight loss alone. So that's a slight difference that has been there. And some of them have been insisting on us having tried something different or also simultaneously having some sort of a lifestyle intervention plan and having evidence that we are trying to do more than just give them a medication.
Okay. Yeah. So I'm curious, what's the cost of Ozempic if they had to pay out of pocket?
About $1,500 a month.
Yeah.
So it's pretty expensive, so it's mostly out of reach for most people. Mhm.
Is it something that's covered by most insurances?
It is covered by most insurances. You know, as you know, the whole system, the way it works, the complexity of copays and deductibles and all those things. So it just varies. Some of our own employees at the University of Louisville who were being covered changed their insurance plan to get a you know um, higher deductible, and suddenly they found that it was from January 1st they had to pay $300 a month instead of 50. So it's quite complicated. So but it is an expensive drug, but a significant number can get it. But I think there are some studies that say maybe only about 10% or 15% of people who are actually eligible to this can actually get it, in terms of being able to afford it.
Great. Any other questions before I go to the next part of the story?
Sorry, I have a question. Is there any serious drug interaction between the antipsychotics and these kinds of drugs? I mean, is there any high risk for pancreatitis or the other side effects if you wanted to use it together?
No, there is no indication that the combination is necessarily going to increase the risk of pancreatitis.
Thank you.
So that is not much of a concern.
Thank you.
Okay, so let's go to the next part of the story. Okay, so she was started by this diabetologist on Ozempic weekly injections, and she was able to lose another 20 pounds. And the nice thing is, she was also able to return to work. She had been trained as an engineer and went back to work as a software consultant. But now she has some, in addition to her delusions, she has some work-related anxiety as well. The delusions are there, and she still is, not very sure she wants to see a psychiatrist. And so there are two questions now. From a psychiatric point of view, how would you approach this? And there is this kind of inconsistent literature on GLP-1 agonists increasing anxiety versus actually reducing anxiety. So the final word has not been said on that, even though I see that more and more literature is positive in terms of potential benefits of GLP-1 agonists in psychiatric disorders. There is also a recent paper I saw on possible pro-cognitive effects and protection against dementia and so on. So question then is, is the GLP-1 causing an anxiety problem in addition to the psychosis that she already had? So what do people think?
Well, I mean, as you said, the data on that has been inconsistent. There certainly I mean, one of the things about the GLP-1 agonists that one should remember is that they are pharmacologic. They are not physiologic, that what we're giving, because normal GLP-1 is a very short-lived hormone secretion occurring around mealtime. And we give the levels of GLP-1 that we get from these analogs is very high and is persistent. Is there, 24 hours a day, 7 days a week, so once a week injection. So all of its effects, and a significant part of it is kind of a pharmacologic effect, which we don't fully understand. In fact, the effect that it has had and the benefit it has shown is a bit out of proportion to what was predicted would happen. We are indeed surprised that it is as effective as it is in so many different ways. And so, there are some mood studies that have been done that it improves mood, it, increases satiety. There is It also actually decreases craving. It is now being used for alcohol addiction. There are trials looking at alcoholic hepatitis and prevention of some alcoholic liver disease. So there are many benefits. At the same time, there are these other reports about suicidal ideation, depression, things like that, which, if you go back and look at the history of obesity medications, this has been a long-standing problem. The conflict between, weight loss, satiety and mood. There are, a variety of explanations that people have come up with as to why these things kind of go together. So some of the changes in, behavior and weight. So in general, the studies that have looked, meta-analysis and small studies, all of them would favor that they would help, but none of them are kind of strict randomized trials which have specifically looked at these kinds of outcomes. So we can't be 100% sure about what its effects will be. It's not something that is that we are too much concerned about. But I think one of the problems in general is that we have to keep this in mind when patients do complain of it. I do kind of think, is there an alternative or anything like that? But I'm not as much concerned, but I can't dismiss some of the patients' concerns about when they complain of these things.
In
Yeah,
this
that's
particular
very.
case, I'm sorry.
Go ahead.
I was just wondering, in this particular case, right, it would be unusual if she didn't have anxiety at that point in her treatment coming back, right? That would be a unique and amazing case. It looks like she's sort of getting the maximum amount of benefit she's going to get out of her Abilify. So it just seems unusual. Like, why do we need another explanation for why she feels anxious?
Yeah, and also the fact that she went back to work.
She's doing really well.
Yeah, so that's yeah, and that could have brought out a normal anxious response to a stressful work
Like this
environment.
psychosis, it's the anxiety is like almost always there as
That's all.
part of the underlying thing,
Right.
too.
So it's there is a more plausible explanation for her anxiety than a GLP-1 agonist. That's what I'm implying. Yeah, no, I agree with that completely. So Max, what do you think? How would you have approached the psychiatric problem at this point?
Does she know that she's taking medicines?
She doesn't know that she's taking.
Still,
No, she still does not know.
does she have? Do they have children, by the way?
No.
You have to tell her. You have to talk about what's going on, and even if it goes awry, I think I would have a conversation at that point.
Yeah, so that's what I told the husband. And he said he has been looking for the right opportunity to tell her, and he had not found one as yet. Well, here is what happened. The diabetologist, who is a good friend of mine, we had a conversation, and I explained the situation to him, and he said that he would bring it up with the patient in the context of her current symptoms of anxiety and explore this further, which is what he did. And when he started talking more to her, she was willing to tell him a lot about not only her work-related anxiety, but also her anxieties about her husband and about her paranoid thoughts and so forth. And also, she came out with the fact that she was having some mood swings, that there were some days she was really having low energy and some days she was really hyper and so forth. So the diabetologist, who was quite well equipped with psychopharmacological knowledge, he took the approach of saying, look, so it appears like you have a mood instability, and you have a family history of psychiatric illness as well, which he had found from her, that her mother was treated for depression. So how about you get a mood stabilizer? which also comes as an injection once a month. So he convinced her to get on to monthly haliperidone injections. So the question of psychosis did not even have to come up, because this is a drug that is used for as a mood stabilizer already. You know, the term dopamine serotonin antagonist is as good as an antipsychotic. And often my patients, the moment you mention the word antipsychotic, they don't want, I don't have psychosis. You take the medicine, not me, that sort of thing. So, so she started taking the paliperidone injections, and now the husband had the opportunity to bring up to her as to how he has been treating her, and that she had responded well to risperidone previously, and that this is what she might be having, and so on. So she is now a little bit more open to the idea, and she is not declining the injection. She's getting the injection. She's doing much better with the um, haliperidone
Is she
systemic.
doing, how is she doing better than she was when she was going back to work? Like, I think it's kind of,
No,
this is a
she's
really
better in the sense that she is willing to accept that there is a psychiatric illness and that there is a need for a psychiatric treatment.
How old is she now? Has it been a few years?
She's probably 34 now, 34, 35.
Do you think that there is an additional like a bipolar component to that, like an episodic component to this, that would benefit from
Her
lithium?
illness has not been episodic. She has concomitant mood symptoms, but there is a persisting illness with delusions. So this is why the best you can use is the term schizoaffective disorder.
So is
So
her sugars better now?
sugar, yeah, again, she's lost about a total of 25 pounds, and her HbA1c is around 7.2-ish. She's doing fine. She works 3 days a week. They're planning to have a baby, so things are okay.
Was she is she pregnant?
No, not yet.
Have they trying to conceive?
Yes, I believe so. Yes. So this, yeah, I think the point earlier, Sri Prakash brought up of, not a statin at this point, so that's relevant. So can you
Yeah.
say more about that, Sri Prakash? What is the risk of statins for pregnant women?
Well, I mean, obviously, it's for the fetus that we don't use the statin. So we haven't. It's not recommend. We stop it immediately after when they are known to be pregnant. Mhm.
Yep.
Are you super worried about this case after, like, going forward after pregnancy in particular? Like, if she's at maximum dose 234 in Vegas Sustenna with some residual symptoms, like, do you refer these folks out for specialty care, or are they gonna have MFM, or how would you address the pregnancy?
It's a very good question. I have not thought through this, and it has not landed on us. She's not pregnant yet, but it's a good question to be thinking about. So your worry is her developing a postpartum psychosis?
Well, just kind of the natural course of the illness. I'm worried that, it does seem like deltas in estrogen lead to exacerbations and worsening of psychotic illness, right? I think that part is pretty well kind of established. That if you're predicting one coming up, like, she's going to have some struggles in that time, I think, that are going to be, you can anticipate some of these difficult periods of time without trying to be too psychic about the whole thing, just based on the course of illness.
Yeah.
And I'm worried that if she's on the maximum dose of Invega Sustenna, that there's still like still maybe some residual symptoms and things like that. This is gonna be
Well,
tough.
the one thing that crossed my mind is whether she could manage with a lower dose of the system going forward as maintenance treatment, because she has been doing pretty well. She's not bringing up any of those delusions. It does not appear to be responding to hallucinations. So
How-
a
how did you
gradual
take-
reduction.
Do you
So
ever
would you
talk-
can you use the drugs during pregnancy?
Yeah. So again, let me see what Dr. Mayer has on that topic.
Oh yeah, my wife does this work. This is her full-time gig. Is women's reproductive mental health. She did a fellowship down at Brown. She would have tons to say on this, but you have to continue medication through pregnancy. And if someone's on lithium, then it becomes more challenging, but that in particular should be kept going as well. I think that, yeah, with lithium, you can anticipate needs going up too as body volume expands. That medication dosing becomes different during this period of time.
Yeah.
And there's
Because one of the things is we'll have to stop the GLP-1 when she gets pregnant, you know.
Why do you have to stop GLP-1?
Well, I mean, because it's not approved for use during pregnancy. You know, they haven't shown any adverse effects. I mean, it's relatively new medication, so you know. But at this
Are
point,
there
we're not
alternatives?
using it during pregnancy.
Well, she's still on metformin. So this was
Yeah.
so could she manage with metformin alone?
It depends, you know. We'll have to see how she, I mean, with having had this weight loss, and you know, she may be able to manage with metformin alone. And again, there are other options during pregnancy. We can
Are
control the
there
blood
others that
sugar.
are safe? For example, an SGLT2.
Correct, and neither one of them are known to be safe. You know, we still don't have enough data to confidently use them.
What about some of the older ones? Are there any other classes of?
Well, I mean, our standard really is insulin. You know,
Yeah.
that's the best drug. We have, there are some studies looking at metformin and sulfonylureas, and they have been doing okay. You know, no significant adverse effects have been
Yeah,
noted.
sulfonylureas have been there for several.
Yeah, 50 years now, you know, or more. Mhm.
There is
Yeah.
no known risk with pregnancy with that, right?
Well, yeah, I mean, it wasn't used until very recently, you know. So
Yeah.
they
But
have.
what we do know is that insulin is the treatment of choice for gestational diabetes, right?
Mhm.
So she might as well go on to insulin.
Correct, at least for that period of time, if needed. You know, it's possible that she may not need it.
That's good to know. But on the other hand, one has to balance. If you think about the antipsychotic, again, data are not as solid, but antipsychotics generally, even including atypical antipsychotics like paliperidone, have been used in pregnancy, and there has not been any clear-cut evidence of teratogenicity. But when mood stabilizers like lithium and valproate are a problem, they do have a significantly increased risk of cardiac and other congenital problems.
The Epstein's associated with lithium. My understanding is the newest data shows that risk is really very, very, very low.
Yeah, that's what I have read also. But valproate does have a significant effect.
Yeah, valproate's dangerous for pregnancy age women.
So thankfully, she's on neither of those. And antidepressants, again, there is a little bit of an slightly increased risk with SSRIs of, congenital problems. So you would want to avoid that as well. Manage her just a lower dose of the injections of the paliperidone, maybe.
Because if you stopped it, she would 100% relapse.
Yeah, so the risk of relapse is very high. Pregnancy is a risk factor in and of itself, and the postpartum period is a significant risk factor as well.
Mm-hmm.
So those
That's
are
true.
good questions.
My wife sees that where a lot of times psychiatrists get real nervous and they just react and stop all medications in women who are either just become pregnant or trying to become pregnant with, serious mental illness, right? Like women with bipolar and probably some psychosis, and psychiatrists get very reactive. But there's numbers you can call if you have questions, right? There's a hotline and stuff like that. Generally, you don't have to stop this stuff except for Depakote and Tegretol.
Yeah, so there is a fair amount of literature and resources to help psychopharmacological questions as they come up for pregnancy and lactation period. Last week, we organized a national level psychopharmacology conference, and we had a lecture on psychotropic drugs during pregnancy and lactation. That was Kathy Lager was the expert, and Elizabeth Greenwald from Mass General. They were speaking. So I can send the link to their slides if people are interested.
There are a couple of newer drugs in development, quite um, advanced stages at this point. There is the triple agonist, which is a GLP, GIP, glucagon receptor agonist, which actually causes even more weight loss than the two drugs that we now have. And there is also a GLP glucagon dual agonist, which also has a lot of cardiometabolic benefits. So I think that, you know, group of drugs is going to expand, and it is a good thing. We just have to try to figure out how we pay for it and how best to use them,
Yeah, it looks like GLP-1 agonists are kind of the rage at this time. Whatever
Mhm.
news you pick up, there is something on GLP-1.
Correct.
And
Yeah.
even, what's her name? Oprah Winfrey talked about it, right?
Yeah.
Recently, as a weight loss thing. I'm sure you get a lot of questions.
Yeah, we have a lot, and they've been used for all kinds of, and we find people who kind of, and there is also this issue of, you get this mail order GLP1s,
Yeah.
so you can get it for $150.
No, I didn't. Okay.
So there are compounding pharmacies, and even they are now advertise on whatever row.co or something is on TV, that you can get this, and you're not sure, how, what the qualities are and whatever, but I do have patients who are using it, and it's more difficult to figure out how much they are taking, and but they seem to work.
How do they work? And is it simply straightforward agonist effect on GLP-1 receptors, or do they have other effects as well?
Well, so they are, direct effects through GLP receptors, but the GLP receptors are widely distributed. So that's the thing, is that it has impact on, satiety, gut motility, insulin secretion, glucagon secretion, so and several other areas where, so that's, it has multiple effects.
I have read recently, Sri Prakash, that GLP-1 agonists have an effect on the dopaminergic system as well, which is how they might have their benefit in addictive disorders. Addiction across the board, whether it's cocaine or opiates or alcohol, they are related to release of dopamine as a kind of a short-term pleasure-releasing neurotransmitter in the brain. And the drugs that work on mesolimbic release of dopamine have a benefit in terms of reducing craving. And what I read recently is that GLP-1 has an effect on brain dopamine as well. So
Yeah, I mean, so the thing about most of these studies, one of the problems that we have is that, most of the, obviously they're animal studies, and they refer to acute administration, and then you study it. But what happens if you take it every week for a year? Will the whole system adapt to something and the thing will change, or will the same effect be seen? Those kinds of studies are still lacking to figure out, what exactly will happen when I give a GLP-1 analog, uh, you know, every week for a year. Is that the mechanism? Because the effect seems to last quite long. That is one of the things about this class of drugs, because typically our previous weight loss medications, you saw that curve where it would go down, then it would kind of flatten out, and you get a weight regain, where you would regain maybe 10-20%. But this drug seemed to have a very prolonged effect, that it still has an effect a year later, that people are either stabilized or still losing some weight, which is quite remarkable in the field. So it certainly has changed the way we are looking at.
in some way resets a homeostatic balance.
Yeah.
Is the effect limited to food and appetite, or does it have other reward modulating effects that you didn't expect, like smoking or something like that? Or is it just
With
strictly
alcohol,
appetite?
certainly there is. With alcohol, there is a decrease in craving for alcohol.
Because it works by food. It decreases appetite mostly, not necessarily changes
correct.
how you metabolize. So it's probably acting centrally mesolimbic reward
It is
pathways.
acting centrally,
Yeah.
Yeah.
What about with self-injury and stuff like that? Has anyone tried it there?
I don't think so, but I know that there are studies with alcohol, because the people who were on this did report that they don't feel like drinking anymore, and then they actually did the study, and now they have it in trial for alcoholic fatty liver.
Awesome. That's awesome.
Yeah.
So what you're saying is it's a psych med. You're just saying it's a psych med.
Yeah, it's probably,
Yeah, I know.
Well, I have heard that some folks talk about it decreasing food noise. So like the constant thinking about food, and that definitely sounds more like a psych thing than a
correct. That is true.
thing.
Yeah, it might reduce craving for not just food, but maybe other things as well, alcohol and
Yeah.
But there is this that it is viewed as a panacea for everything. So we have to be cautious about that.
Correct. It seems to be, when something has these broad range of effects, you also think maybe it has a broad range of side effects. So one has to be careful.
Yeah. For that reason, I'm also fascinated by metformin. Metformin is a cheap and simple and straightforward drug. And there are people who say that it can lengthen longevity and reduce inflammation. So what do you think about that?
Well, I mean, I think there is a fair amount of data regarding that, the issue of longevity. There is also some studies looking at cognition in older individuals, that improves cognitive function, or at least maintains cognitive abilities longer. So I think there is some truth to it. Some of us would think that maybe it is due to changes in gut microbiome, that it does some of these changes. It certainly changes the microbiome. So do the GLP-1s and other things. And that has also been kind of postulated as one of the mechanisms by which, because I think mood is also affected by microbiome.
Yeah.
And so, so there may be the exact pathway by which these are working may be more complex than just, one.
Yeah, so that brings me to another case that I'm currently treating. This young lady, 26-year-old, has put on about 30 pounds on risperidone. And more recently, I changed her medicine to Vraylar, cariprazine, which is one of the less likely ones to cause weight gain. No diabetes. She, HbA1c is like 5.2. But interestingly, her CRP is 21. It's pretty high.
Mm-hmm.
And her PCP does not know of any other way to explain that other than maybe obesity itself. So I put her on metformin. So, with the idea that maybe there is an anti-inflammatory effect of metformin, which will kill two birds with one stone, to reduce her weight, protect against diabetes, and also maybe improve cognition. Who knows? So, what do you think? Someone like that.
So, I mean, the CRP is a way too high for simply chronic inflammation,
Yeah.
subclinical inflammation. So, the one question that I have is she on a birth control pill?
No.
Okay, because birth control pills raise CRP just by making synthesize more CRP. So, so otherwise, this degree of high CRP is more typical of a inflammatory process that is, joint or something else.
Maybe you
than
should
just-
do a lupus screen on her or something like that.
Yeah, something should be looked at before we attribute it to chronic systemic inflammation.
Yeah, that's helpful. This is very, very helpful, Sri Prakash.
Mhm.
There are a couple of minutes. Are there any other questions that people have?
I mean, I think one of the things that we have in general in dealing with this complex problem is the lack of sufficient number of psychiatrists and endocrinologists. So it's very difficult to get into either of their office.
No, that's one thing. The other thing is psychiatrists and endocrinologists don't often talk to each other.
Correct. Mm-hmm.
So that is
Yeah.
where we need
Yeah.
to make communication. And in this case, this I brought up because of a great collaboration between a psychiatrist and an endocrinologist that worked for the patient's advantage.
Mm-hmm. Yeah.
Diabetologists are served like a psychiatrist for this case.
Mm-hmm.
I think we need to do more.
Yeah. Mm-hmm.
So thank you very much. Really
thank
appreciate
you.
your help and look forward to seeing you sometime soon. Yeah.
Sure. Take care.
Yeah, thank you.
Thank you very much.
Everyone. Yeah.
Bye.